I'd just like to invite everybody tonight to our webinar from MHTN. It's an interdisciplinary panel discussion. The topic is bipolar mood disorder, working together, working better. The panel tonight is a talented one. We have Ms. Ingi Barr, a consumer, Professor David Castle, a psychiatrist, Associate Professor Greg Murray, a psychologist, and Dr. Mary Emilias, a GP. I'm your facilitator tonight. My name is Michael Murray. The webinar is hosted by MHTN. This is a Commonwealth-funded project supporting the development of sustainable interdisciplinary collaboration in the local primary mental health sector across Australia. We currently support approximately 450 local interdisciplinary mental health networks. For more information or to join a local network, visit www.mhtn.org.au. The learning objectives tonight are two. At the end of the session, participants will, one, better understand the key principles of intervention and the roles of different disciplines in providing integrated mental health services to bipolar mood disorder presentations. And secondly, will better understand the merits, challenges and opportunities in providing integrated mental health services for people experiencing bipolar mood disorders. To find out more about your individual discipline's CPD recognition, visit mhtn.org.au. The webinar is in two parts. Initially, we will have each presenter, consumer, psychiatrist, psychologist and GP present some PowerPoints. Afterwards, we will have questions passing between the panel, and then it will be your chance to have your questions answered from the audience, and that will be facilitated through me. So if you have questions that occur during the evening, just pop them into that message panel in the bottom right-hand corner. I would also remind you that frequently during the evening we will be flashing out a 1-800 number if you're having technical difficulties, and this also contains a code by which you can phone Redback to receive SAND if you're suffering from SAND problems. That 1-800 number is 1-800-1425-16. There is a passcode there. You will see it in the bottom right-hand corner. Now, there are some ground rules. I will moderate the panel discussion and field questions, as I said, from the audience. If your specific question is not addressed, or if you want to continue the discussion, feel free to participate in a post-webinar online forum on MHTN Online. Ensure, if you are not a part of the panel, that your sound is on and your volume is turned up on your computer. If you're experiencing problems with sound, as I said, phone that 1-800 number. The webinar recording and the PowerPoint slides will be available 24 hours after this activity on the MHTN website. Now, we would pass over to Ingi Barr. Ingi, would you like to present your perspective, please?
Yes. Good evening. I'm Ingi Barr. I'm a mental health advocate. I'm the opening act tonight. It makes me want to put on my dancing shoes and my sequins and spandex, only I won't, and you'll thank me for it. I'm here to humanise Sandra and give her a voice. My role is to remind all people who are working with Sandra that under the symptoms of the illness known as bipolar disorder is a human being, and that her humanity needs to come first. Sandra's integrity, dignity, vulnerability and her safety all need to be taken into consideration and are supported and protected. At the time of her referral, Sandra is very anxious and her cognition is still dodgy and needs to be addressed. However, she has largely become lucid again and now has insight. Insight is a double-edged sword, however. With insight comes the knowledge of how to deal with and manage the illness, but it also brings the shock, pain and embarrassment to Sandra that she has been mentally ill. This awareness has made Sandra particularly fragile and vulnerable. Sandra is currently facing a number of complex and difficult issues. Number one, having recently discovered she has been diagnosed with bipolar disorder, Sandra is very frightened about having the illness, does not know a great deal about it, and is very frightened about getting unwell again. Number 2, she has also recently stayed in a psychiatric ward for the first time, which at times really unnerved her. Number 3, she is currently trying to adjust to medication she has never been on before, which feel very strange and unfamiliar. And they are strong medications, let's not forget that. I think I'm up to number 4 or 5. Although Sandra no longer believes she is carrying a baby messiah, she's extremely anxious about having unprotected sex with a stranger, and that this could mean she could either fall pregnant or that she has picked up an STD, or maybe both. Number 6, Sandra is also extremely worried about losing her job, a job she loves. Losing her job can impact on Sandra's life in a multitude of ways, not least that she risks losing her home, which is an apartment she rents on her own, and will have to move back in with her parents. This would mean losing her independence, which Sandra values dearly. Number 7, Sandra is also very anxious that if she does not lose her job, will she be able to face her workmates again? And will they accept her? And how will she become work-ready again? On this particular note regarding Sandra, I wonder if everyone who's participating in this webinar this evening can cast their mind back to a time when you got hideously drunk on alcohol. And because your brain chemistry was under siege from the effects of the alcohol, you said and did a number of things in front of other people you would never have done otherwise. People who remember what you said and did, even though you don't. I believe that if everyone was honest, most of us have all been there at some stage. I know I have, several times. And then you had to go through all the shame and embarrassment of facing up to all your antics once you were sober again. But you had a choice to get drunk. Sandra didn't choose to get ill. And what Sandra is now going through is something very similar to having a nasty and revealing hangover. She's facing all the humiliation, guilt, shame, and massive embarrassment about her behaviour in front of her colleagues while being unwell. And adding to her woes, she is also worried about being unwell in front of other people who aren't her workmates, like family and friends, etc. In conclusion, Sandra is going through that painful and awkward transition of being ill to being well again. She has to make sense of her life again. She has to pick up the pieces and work out where she is and what she is. Will she survive this process? Because not all people do, and this is a reality. So Sandra's safety at this transitional stage is paramount. You can see the multiplicity of needs and concerns that need to be addressed with Sandra, and all are critical. It's not only her medical needs, it's her psychological needs, and it's her needs concerning her lifestyle. All of her needs are long-term, as bipolar disorder is an illness you have for life. It's important to note, too, that her issues regarding lifestyle can impact upon her illness. I believe that with a greater collaborative and cohesive network involving all the mental health professionals that will be part of Sandra's life, her psychiatrist, her case manager, her GP, her psychologist, her social worker, etc., Sandra has the best chance of having all her needs and concerns addressed holistically. An integrated, broad-spectrum approach involving all her mental health providers would promote not only greater quality of life for Sandra, but her chances of being able to live with and survive her illness as well. Thank you.
Thank you very much, Inge. Thank you very much for that. I'd just like to remind all our attendees that you can converse by typing into that box on the bottom right-hand corner and then clicking on the arrow. You can also put questions, and we will be cognizant of your questions. Thank you very much for that, Inge. And now
you're welcome.
We will now just move on to David. David.
So I think Inge's given us a beautiful sort of insider's perspective on things, and for clinicians in the field, I think it's a very useful perspective to bear in mind when we're dealing with people who we would label with this disorder called bipolar. I think the keys from the psychiatric point of view in this particular scenario with Sandra is that she experienced a change in her usual way of being, so a change in her behaviors, a change in her interactiveness with others, and some of those behaviours were manifest in a very classic form, which would make us pretty confident about making a diagnosis of bipolar. Of course, when people are experiencing these changes in behaviour, we also need to ask ourselves why it's happened to them at this time. The construction about bipolar would be that most people who have bipolar obviously have an underlying vulnerability to mood instability, and then certain things happen in terms of stress, which precipitate episodes. We also need to be aware that sometimes in people who don't have an underlying bipolar disorder, they can manifest symptoms and behaviors of this nature. And we need to ask ourselves whether that might be going on, especially in a first episode. And I'm thinking particularly here of precipitants such as illicit substances. Amphetamines are obviously the most likely to manifest in this sort of way, but other substances like cannabis at high dose can as well. So we need to bear that in mind. We need to do a thorough workup, obviously, to exclude organic factors, and then we left with the containment of immediate risk. Now, Ingi, I think, has touched on some of this, that Sandra was at risk in terms of her reputation. She engaged in unsafe sexual relationships, which is quite unlike her, and also had potentially impacted negatively on her standing in the work environment. And that's a whole dialogue which I think we might pick up in the discussion later about how you deal with workplace if you have a bipolar disorder. So those are the main points I'd like to make at this stage. I think coming back to what Ingi's issues, the way she's raised it, I think reassuring of Sandra that she's safe and will be held safely by the treating team, that she'll be given as much knowledge as is required, that she'll be helped to understand and manage this underlying vulnerability. That would be the general dialogue which we'd like to have with her. Medications might well be part of the treatment of Sandra in the long run. In fact, for somebody who's had a bipolar manic episode, it's very, very likely that she will be recommended to have medications in the longer run. And we need to be able to handle that discussion with her very sensitively as well, and help her understand the potential benefits and side effects of medication. So I think that's enough from me right now.
Thank you very much, David. That was a lovely presentation. We'll now just move on to Greg Murray, the psychologist. I'll just move on to your slide, Greg, sorry.
Yes, hi everybody. Thanks for this chance to join in this discussion. I'm looking forward to it enormously. I think Ingi gave us a great introduction to the sort of personhood of Sandra and how we need to keep that in the forefront of our minds. And David, of course, has introduced us to, you know, the acute nature of the psychiatric symptoms and our need to understand what has triggered this. What I'm emphasising in my little 2-minute blurb now is how, as a psychologist, I might think about working with this person. I'm assuming they've been referred to me for adjunctive psychosocial treatment. That is, they'll be receiving treatment from me, and they'll be receiving, almost certainly, as David said, medication treatment as well. And so I just wanted to give a very, very brief overview of what model we'd be using with Sandra. And just, by the way, I have some insider's knowledge. I wrote this case study. Sandra isn't her name, but I met her 20 years ago. I saw her today, and you'll be pleased to hear she's doing extremely well. The first aim for me ties in very much with what Ingi was saying. We've got a person here who's just been through a traumatic event. And my first job is to make them feel understood and supported in that traumatic event, in helping them come to terms with what that means for them, what it was like for them, that I am concerned about the nature of that acute experience they've just been through. The other thing I'm very committed to doing in the early phase of working with someone who might have this diagnosis is I want them to not slip into a despair about the fact they've just had a crisis, because as we all know from our own lives, when things are tough, we are a bit prone to thinking pessimistically about the future. And my stance on all my clients is, we know that roughly 50% of people with a diagnosis of bipolar disorder do quite well. But that's just a random sample of people with bipolar disorder. I'm assuming that someone who has found their way to me, and I specialise in this work, and I'm well connected to psychiatrists and other helping professionals, and I'm well connected to consumer support groups. I'm assuming that most of my clients will be in that good half, and in fact I'm also assuming that over time it'll be the proportion of people who do well will be continuously growing. So I will always communicate to people with bipolar disorder that I am looking forward to a situation that, yes, this is we don't have a cure for this condition, it won't go away, but the ability to manage it throughout their lives will steadily improve, and I'm confident that we will be able to increase their chances at least of ending up in the category of people for whom bipolar disorder is a relatively small part of their life. Then I'd move on to the second step, is working out a bit more about who the person is, and obviously with Sandra we'd be looking potentially for some comorbidities. As you probably know, bipolar disorder rarely occurs on its own, and there are two major chunks of comorbidities: substance abuse type problems, and the other chunk is anxiety type problems, and it looks like Sandra may well have something in that area. And then, of course, to echo what David and Ingi have already been saying, we also want to make sure we don't forget the person as we're doing our case formulation, and so I'll be very interested in what her strengths are. We can clearly see from the case study that she is employed. She's employed in a responsible position, and so there's some strength right to start with. And we want to know more about her more broadly as a person in terms of how she engages with the world. And then, and only then, will we move towards some goal setting. So, for example, in terms of, we would set goals for the work, but our goals aren't necessarily decreasing the symptoms or increasing her skills around bipolar disorder. She may have some goals around grief and adjustment to this inpatient stay that she's just had, which is a bit different from actually focusing on improving her or decreasing her vulnerability to bipolar disorder. Then stage 3, in a sort of very rough, broad 4-stage model of working with someone like Sandra, is we would introduce this model as David did, the notion of stress vulnerability. A lot of our clients have an oversimplistic, perhaps a reductionistic model of bipolar disorder, that it's genetic, therefore biological, and therefore only biological treatments are relevant. And so we need to introduce them to a stress vulnerability model. And of course, once we introduce that, we get to what is really the core of the psychosocial work, that is a sort of chronic disease management model, that the person themselves is central in their own management, and they have, as it were, the steering wheel in their hands with regard to staying well. As part of that broad psychoeducation package, then we start the talk of who's going to be on the team. And this notion of a team approach is critical, so there will always be, in an ideal model, and this is what the consensus treatment guidelines tell us, there will always be someone with the medical specialisation and someone with a psychosocial specialisation, but there will also be other people, family members, etc. And then, and maybe I can talk a bit more about this step 4, which is the specific psychological interventions we would be doing. Maybe I can talk a bit more about these later, but we will be working behaviourally and cognitively on what we think are the core vulnerabilities, which is stuff about social rhythms and sleep, reward sensitivity, and the power of planning for relapse prevention, and some specific skills around trying to break those, what we would call manic and depressive spirals that we think people have the capacity, that there are behavioural and cognitive skills that they can learn to diminish the effect of those depressive and manic spirals. That's enough from me.
Thanks very much, Greg. That was good. We'll just move straight on to Mary now. Mary, I think I'll let you move your slides yourself, and if you're comfortable doing that.
Yes, sure. I think I filled up my slides a bit too much and wrote too many.
No, I don't think so. They look like good slides.
So a lot of what I have to say is, duplicates what other people have said. So I guess I answered it in a more general way, so some of it's not directly related to the Sandra case, but I just had some philosophical points that I have found to be important over the years. So one of the things is that mental illness, and maybe bipolar disorder in particular, it's not like pregnancy. So we can't just do a test and say they have it or they don't have it. Can't do an X-ray and say, yes, it's broken. And so I guess the point is that all human behaviours are on a spectrum, and who is it that decides what is normal and what's not? And so I guess going back to the first point, I think it was David who was saying that the point is this is a change for her. So I think it's very important to be aware of your own biases and views about things, especially questions about morality, which are sensitive kind of issues. And I guess in the Sandra case, she's just started up a new relationship with an older man she met on the train, and some people might, perhaps the point is it's out of character for her, but that may be well within the normal range of human behaviour. Following on from that, my personal view is that I think bipolar disorder is often overdiagnosed, and I think that true bipolar disorder is actually quite rare. It's not a high prevalence disorder, and therefore as a GP, if I am considering it as a diagnosis, I think it's really important to refer to a psychiatrist. A lot of my practice has been in rural areas, and psychiatrists may be hard to come by, so sometimes that might be by teleconference or at least ringing up for advice, but I think it's really important as a GP to be seeking advice from a psychiatrist rather than just making that diagnosis yourself. Just changing my slide slowly. So I guess if I was to see Sandra in my rural general practice, and we're 200 kilometres from the nearest mental health inpatient unit, my first immediate thing I'd be trying to establish for Sandra is to get her some sleep. And I guess the major tranquilizers will achieve that. Her nutrition's probably dreadful. She probably hasn't been eating regularly. Her sexual health might be at risk. She may be pregnant. She is probably more prone to injuries and accidents and minor illnesses because her whole system's kind of in overdrive. And there are some biological precipitants which can create manic-like symptoms, if not true mania. So that's been alluded to before. I guess something we haven't thought about, a practical thing, is should she be driving? I don't know the answer to that, but it's probably something GPs think about. I'm just waiting for the slide to change. So then the other thing is it's already been discussed. So what has happened? Generally something has probably triggered this episode, and is there something which actually does need some immediate support or intervention, or perhaps she's really worried about a relative who lives on the other side of the country who's got cancer, or goodness knows, and I think it's important to see if there's anything we can actually practically help with. Then she definitely needs time out. In this case, she's going into an inpatient unit. I think sometimes it is possible for people to be looked after by appropriate, sensible people with the main focus to slow down, to sleep, to eat properly, to reduce all those stressful stimuli. She's going to need time off work for herself and her patients, and of course our aim is to prevent further harm. And then I looked at the post-acute episode, which is where, in this case, I would probably actually see her. So it's been mentioned before, it's basically not only a psychological trauma having an acute manic episode, but it also affects your many body systems, and I think people probably take months to recover properly. So even if their blood tests and so on are normal, I think that their physical body is just not really functioning well for some time. So they can be very exhausted, tense, gastrointestinal upsets and so on. Then we've got to look at her longer-term sexual and reproductive health care. Again, nutrition, sleep, physical activity is going to be important, just general routine and life balancing become more important for someone with bipolar disorder. I think they're important for all of us, but they're particularly important with bipolar disorder. And then she's going to have come out of hospital on some fairly major medications, which do have major side effects. And so one of the roles, I think, is monitoring medication, but also answering her questions and educating her about how to stay well and take those medications. And then I guess many of these things have already been mentioned. So I personally think that psychotherapy of some description is an essential part of her healing, not just from the acute episode, but perhaps the things that have precipitated it, and even if it's just psychoeducation about how to manage in the future. Further exploration of what happened, and it may even be things from long past that need addressing. That will be a matter for Sandra and her therapist. Recognising that the diagnosis and treatment itself has probably had distressing aspects, and that's already been discussed. And then she's probably going to have a lot of fallout in her relationships, and she may need support as she deals with that. And then educating her caregivers and significant others. Again, the idea of hope, that recovery is actually a meaningful possibility. And I think one of the key things is referral to consumer networks and support groups. She may need a lot of time off work. She might need advocacy with her employer or with Centrelink. And not in Sandra's case, but I think one thing that sometimes GPs don't realise is available, there's some excellent disability employment services who specialise in mental health. So that's enough from me for now.
That's great, Mary. Thank you very much. That was a lovely presentation. I'd just like to just ask on behalf of our attendees, I'd just like to ask David the first question. A common question that was coming up on text there was the prevalence of bipolar affective disorder and whether some people are being diagnosed unnecessarily, particularly in children, and also how common is it over the age of 65? I was wondering, David, if you could comment on that, please.
Yes, sure. Look, they're really important issues. Most people would accept that bipolar 1 disorder, that's the disorder associated with florid mania and requiring hospitalisation usually, such as in Sandra's case, that's pretty clear-cut as a disorder and affects about 0.5% of the population. What's much less clear-cut is so-called bipolar 2 disorder, which is associated with depression and then hypomanic symptoms, which are less severity than mania, and they don't necessarily get into treatment. And there's a lot of debate about this as to how common it is, and I think that some people are concerned about the overdiagnosis, especially of bipolar 2 and also bipolar 3, and that it might be an overlabeling of what is really normal mood variation. So that's important to view. I think in terms of a dimensional approach, I think it's a much more useful approach to people with variations of mood instability, and at the extreme pointy end of that dimensional vulnerability of people with bipolar 1 and then bipolar 2 somewhat less, and other people with what we would call probably cyclothymia. They tend to have this predisposition, but it's not a predisposition to mood instability of such a severe nature. The key to diagnosis, though, is the longitudinal, well, obviously the symptoms themselves, but really the longitudinal course, and whether this is seen as a recurrent episodic illness, which is the characteristic of bipolar. Whether it can onset in children, I must say I'm very, very concerned about the fact that in the States there's been some 400 to 4,000-fold increase in diagnosing bipolar in children, and unfortunately that leads to unuseful labeling and pathologizing what might really be normal behavioral manifestations of development, certain developmental phases, and often a reflection also of other things going on in the family environment. And unfortunately, in the States at least, a lot of these kids are landing up on medication at a very young age. I think that's extremely worrying. And the long-term follow-up studies have been quite clear that these kids, although they're labeled with childhood onset diagnosis of bipolar, actually in the long term don't have bipolar disorder. So I'd be very, very wary about it in children. Adolescents, yes, maybe But you also need to bring the developmental perspective into that scenario as well. Just very quickly, the very late ones, I'm always, the general rule of thumb would be if somebody's having a first episode of mania in late life, and over 60, I'm referring to, it's not really late life, it's somewhat slightly less young than other people, yes. But you always really need to start thinking about whether there are organic factors, and we've already heard about what some of those might be. So that would be the general response to those questions.
Thanks very much, David. Now, Ingi, I believe that you had a question you wanted to ask Greg, our psychologist.
Oh, yes. Hello, Greg. My question to you is, would you say that the majority of people with bipolar disorder make use of psychological counselling, or is it the minority?
I saw your question, and I thought, not only do I not know the answer to that question, I don't even know how to find out the answer to that question.
Oh, no. Sorry.
Yeah, so thanks very much for a great way to show my expertise. I'm not even sure how we would work out how many people are accessing psychological services given a diagnosis of bipolar disorder. The only thing I can say is, I was trying to think of an answer to this question. My sense is, I guess it's probably increasing as we become more aware of the biopsychosocial nature of this disorder, and we publicise it more, and we're involved in these sorts of discussions more. I trust that more people are realising that simply seeking out medication treatment for it is not the ideal way to manage even bipolar 1 disorder, and definitely conditions further down that spectrum, further away from the pointy end. Definitely psychological interventions are going to be useful, but in terms of the data, I don't know. Does anyone else have an idea how we'd work that out? Maybe Medicare stats might give us an idea.
Yes, well, actually, one of our attendees has just texted that possibly the Better Access program through Medicare would have some stats on that.
Yeah.
But that's a really interesting question.
It is.
Yep. Thanks very much for that, Ingi. But just to go back to you, Greg. I mean, I know you're a statistician, and you would find it challenging to give an answer unless you had the stats in front of you. But what's your gut feeling?
My gut feeling is it might be a minority. My gut feeling is that for bipolar 1, which, as David said, we typically notice with a manic episode, so it started very much at the medical end of the treatment spectrum. And my gut feeling is maybe a whole bunch of people who start their experience of bipolar disorder there don't find their way to a broader understanding of the condition, and maybe in that panic associated with a very serious psychiatric episode, they and their family members don't look beyond the biological treatments. Yeah.
And Ingi, can I just give you a quick response to that? What was behind that question?
Well, I'm a bit of a therapy counselling tart. I love going to see, I love working with my cognition. I need to from time to time in order to keep managing my illness. And I get, over the years I've had enormous benefit from that. But my general feeling is very similar to what Greg was saying, is that quite a lot of people don't do it. They rely on the medications and don't actually work with don't do the cognitive sort of psychological stuff. So that's what my feeling or reading that I've had of it. And so Greg, your answer is pretty much what my sense of it has been as well.
Thanks, Ingi. That was great. Thank you. Now, Mary, do you have any questions for David?
May I just respond to that one as well? I think one of the other reasons why people don't consider psychological therapies straight up is because they're probably not told about it. And I think there's been very much a medical model view of managing not only bipolar disorder but mental illness in general, and it's been, that has come to mean pharmacotherapy. And I think that's probably swinging back a little bit the other way now, and we're, starting to realise that that's just part of the story. So I think hopefully people are getting encouraged to participate in other therapies a lot earlier, and also to join consumer support, to find consumer support. So my question for David was, he's already answered it, Michael, which was about whether he thinks bipolar disorder is being overdiagnosed.
Okay.
We've sort of discussed that already, and I guess there's been some comments from the audience about bipolar 2 and bipolar 3 as we've gone along. David, you mentioned bipolar 3, and could you just
I've just
let us know what that is?
I just responded online, but I'll say that again verbally. So some people use this term bipolar 3, and there's two main ways in which that term is used. The first is for people who are sort of a bit hypothymic, by which I mean they always seem to be a little bit peppy, a little bit over-enthusiastic, and generally sort of happy people, but also on top of that suffer from depressive episodes. Some people would label that bipolar 3. Another way in which bipolar 3 is used is those individuals who only ever get manic or hypomanic when they're exposed to antidepressants or ECT. So those are ways in which that term is used.
Thank you.
Good. Now, David, I might ask you to ask Mary a question.
About bipolar in particular. Well, Mary, I'm interested in, the holistic care of people with bipolar, I think, clearly has to involve the GP. And what we often find, though, is GPs might be reluctant to take on people with bipolar. And some of the reluctance is because of past experience with communication or lack of communication, particularly with psychiatrists and mental health services. So could you point us to what the most exasperating aspect of psychiatrists are for you in dealing with people with bipolar, and what we can do about it to do it better?
Well, can I first say that I can't really from personal experience, because I've generally had good experiences with the psychiatrists locally. We also do a lot without psychiatrists because we don't have a lot of access to them. But I suppose
You did allude to, sorry to cut across you, but you did allude to some psychiatrists being terribly biological and...
Yeah, I mean, that would be my main exasperation, is that the failure to consider a holistic view. So I guess I have a perhaps not related to bipolar disorder, but maybe more for the higher prevalence disorders. But I kind of sometimes feel, how can I be prescribing a psychotropic for someone when I don't even know if they eat breakfast? And I have people who, have dreadful nutrition, no sleep, high stress, and they live on energy drinks, and they have a Red Bull and a cigarette for breakfast. I feel a bit awkward about prescribing medication for them without actually addressing those issues first. And I guess sometimes some psychiatrists are very biological and don't tend to make sure those things have been addressed first. And I guess the other thing is, between any of us, and I think GPs are just as guilty, is communication. And so if someone has their medication changed and I need to be writing the next prescription, I need to know what they're taking. Often the patient themselves knows, but sometimes there's been a lot of changes and they lose track, or they might be on a whole lot of other medications for chronic conditions, and it's quite important to actually have communication. The other thing I find really helpful is under Medicare now, we often refer people to psychiatrists for a one-off appointment for an assessment and management plan, and that management plan needs to be, predictive. So over the next 12 months, this would be the ideal thing to do with the medication. I find that really helpful.
Yeah, somebody's just sent a message saying patients sometimes persuade the GP to switch medications or the psychiatrist to switch medications, and the knowledge about the switches isn't often relayed. One of my ways of dealing with that is to persuade people with bipolar the key. They're in fact the only store point in the turning world. So they're the only ones who can really carry the knowledge. And keeping a diary which is a mood diary, which is very simple, but which records any changes in medication, and that actually goes with them to every appointment with any health professional involved in their care. I think it's the only way that can really be done.
Yeah, and I think with regard to switching, there's some really good guides to switching in the psychotropic guidelines, in the therapeutic guidelines series, and also in the Australian Medicines Handbook, both of which you can get online. So they're useful resources for GPs.
May I just pop in there, because Inge had a really good question that she had flagged that she may ask you, Mary, along this very topic. Inge,
hi, Mary.
Hi, Inge.
I'm sorry, I've got a bit of a curly one here. It's a bit long, but I'll plug away. A friend of mine with the fictitious name of Simon went off his medication for 5 months. The only person who knew about this was Simon's GP, who at the time was giving Simon his fortnightly injection of medication. Apparently, due to patient confidentiality, the GP did not inform Simon's family or Simon's psychiatrist that Simon had done this. Simon consequently became very ill. He required 2 hospitalizations, had altercations involving traumatizing members of his community, which led to police intervention and court appearances, and it took Simon 2 years to be fully well again. In that 2 years, there was an enormous amount of resources and people power required to get Simon well and back into the community. So my question is, as a GP, why does the rights to why does the rights to patient privacy override the rights of family and community to live without fear, harassment or trauma?
Thanks, Inge, for that really simple question.
I'm sorry, sweetie.
That's okay. I guess the first thing I'd say is it sounds like it was a really difficult situation for everybody, and I don't feel that I can really comment on that particular scenario. But I guess, except to say, probably if I was administering a depot to someone fortnightly, generally that suggests to me that they have been very unwell, and probably if they were wanting to go off it, I wouldn't contact their family, but I probably would contact the psychiatrist for advice. But I don't know what the situation was, and I guess I don't think that I actually think that the patient's right to privacy can coexist with the rights of the family and community to live without fear, harassment or trauma. In an ideal world, I recognise that doesn't always happen. I suppose somebody's request to go off psychotropic medication to me doesn't always mean that is their illness. There may be other reasons why they want to, and sometimes they may find one health professional who may be the only person that's kind of willing to listen to that aspect of their story. So it's a really tricky situation. I think if somebody's well and they're a voluntary patient and they don't want to take their medication anymore, ethically they have a right not to take it. The difficulty happens if and when they then become mentally unwell. And sometimes the changes can be really subtle. So the point at which you make the decision to override someone's right to privacy is a really difficult question. So I don't know that I can give you an answer.
I think that was a great answer. Thank you.
Can I comment about this? Because, I think that there's a different dialogue you could have with a patient who came to you and wanted to start changing their medication, and especially, I think, the signal, as you've alluded to, with regard to switching from a depot. And I think it really is incumbent upon the person, the GP or the psychiatrist, then to say, look, I'm just not comfortable in doing this without having a full discussion with you and your family and the other people involved with your care, because I'm really concerned about the implications for you. And I think that's a totally legitimate discussion to have, and you can say, this is my call. You're asking me to do something which I don't feel comfortable with without having the involvement of others.
I guess the ones that I find difficult are where I'm not even sure that I agree with the diagnosis. So it wouldn't be not so much the bipolar 1 patients, but I think bipolar 2 is very tricky. And I think sometimes friends and family and other people can be very invested in maintaining a diagnosis and staying on medication. And sometimes the client actually needs to have a place where they can talk about their uncertainty about that. So
yeah, but even that would be, to my mind, it would be a very useful discussion to have with family, so that everybody can have their say.
Yeah, absolutely.
Yeah, there are different views about it, and it's an opportunity for educating everybody, I guess.
Good. Thank you very much. That was a lovely conversation. Now, David, I believe that you had a question for Greg around psychotherapies.
Yeah, Greg, I know that you obviously very much got your head around the cognitive behavioural approaches to the treatment of bipolar, and we know that CBT certainly has benefit for the depressive pole at least. We know that social rhythm therapy has benefit. We know that family interventions can have benefit. I was wondering whether you could comment upon the role of the so-called third wave therapies, ACTs, and so forth, mindfulness techniques. Because I think some of that discussion with patients and the dialogue is again a very useful one in terms certainly of engagement and acceptance of the underlying vulnerability, or stress vulnerability strengths model is quite compatible with the ACT discussion.
Yeah, absolutely. The first thing to say, David, I think it's a really good question, and I actually think it's probably something that the researchers will be doing over the next few years. Very little empirical research into that question has been done. I've seen 3 or 4 small studies looking into mindfulness-based therapies, sort of in terms of feasibility. And you're right, the people with diagnosis of bipolar disorder do respond well to that the sort of cultural assumptions, if you like, or the values that underpin those, what we call the third wave therapies. And just for people who don't know, these third wave therapies are really psychology meets Buddhism. So it's a pretty good idea, really. And it's taken psychology by storm. You can't talk to a psychologist these days without them raving on about the importance of mindfulness. So it's not rocket science, it's Buddhism. And all the feasibility trials to date suggest that this way of looking at thoughts, this sort of way which assumes we should observe our thoughts as just passing mental experiences and not get caught up in them. Now, you could just see that as one cognitive behavioural therapy strategy. That's one way of viewing that approach. But there's a sort of deeper meaning in these third wave therapies, and we see it in ACTs, for example, acceptance and commitment therapy, where there's another sort of approach in there which sort of says to people, work out what's important to you in life, work out what your values are, and then ask yourself the question, are these behaviours I'm engaging in consistent with those values? And are these thoughts that are crossing my mind distracting me from those values? So I think the active ingredient in these third wave therapies, beyond cognitive therapy, beyond the idea that we should monitor our thoughts, the active ingredient is really this idea of working out what sort of person you want to be and acting in accord with that. So, yeah, the data's not in, but I would be very surprised if there isn't a large-scale study of that in the near future, because it seems to tick a lot of boxes.
Yeah, look, I agree. I think that we'll see that. And my experience is some people really sort of get it and like it. A lot others maybe prefer a more sort of mechanistic approach. I wonder, Ingi, could you comment upon what Greg said in terms of your approach to how you've managed your...
Well, I love the idea of psychology sort of blending with Buddhism.
You love psychiatrists more, don't you?
I love you all. I'm really lucky I get to interact with lots of wonderful people. Greg, I've just started with a psychologist again 2 weeks ago, and she's going to be working with me with the mindfulness. I think it's going to be a combination of the mindfulness and the ACT. I haven't done this type of therapy before. I've done everything else, I think, over the years. I liked cognitive therapy myself. I've done CT and CBT and, a whole stack of things over the years. But I really like this concept that I've heard about the mindfulness, about it's almost like, say for me in particular, my biggest problem is my paranoid thinking. I have terrible social paranoia, which very much compromises my integrity as a person. And so being able to separate out myself, the true person that I am, and then finding a way to be comfortable with the other part that is unpleasant to live with and can really interfere with my social interactions with people, and somehow finding some sort of peace between those two parts of you. And I'm really looking forward to exploring that, and I see it as embracing or somehow getting comfortable with your wounded self, if you like, the part of you that has over the years developed a very powerful defense mechanism about you and the rest of the world, but to the point where it interferes with your life, and then you've got to try and find some sort of a way to sort of accept that part of you but not let it override your thinking to the point where it creates great destruction for me in my personal relationships with people.
Yeah, they use the people who use this sort of approach talk about the challenge of not fusing with your negative thoughts. So we all know that experience where something crosses our minds and we own it as if, that tells a deep story about who I am. But these third wave approaches are very much about saying, in that Buddhist way, these thoughts are like clouds in the sky. Let's just let them pass. Let's not assume they're giving us deep insights about our nature.
No. And I do like that analogy with your true self is the sky, and the negative thoughts and whatnot pass like clouds. And they do pass. They're not permanent. Your thoughts do move on, and you have to be very mindful of that and not act on things or whatever, obsess about things. So I'm very much looking forward to my new adventure with my new psychologist and doing the mindfulness and the ACT.
One of the things that differentiates these so-called third wave therapies from the cognitive therapy and cognitive behavioural therapy is those two, the cognitive therapy and the cognitive behavioural therapy, really grow out of a strong behaviourist tradition. And some clients don't like that so much because what comes with the behaviourist tradition is a strong emphasis on structure and record keeping, quantification.
Which is good when you've got OCD. That's probably why I responded to it quite well at the time.
I just come in though because I think structure is critical for people with bipolar, especially the social rhythm structure. And somebody was asking a question about that. I think certainly sleep is an absolutely key part. So getting to sleep at a certain time, getting up, getting into natural light in the morning. I call this, instead of black dog, this is white fluffy Labrador therapy, where they come and lick you on the face and drag you out of bed for a walk first thing in the morning. So social rhythms, key part of it if you really talk about structure. But I agree with you, some people don't like the rigor of the behavioural interventions.
I'd just like to bring Mary into this conversation. We do have a technical issue with having more than 4 people showing. So I'm gonna leave the screen, but I'll still be in the background. So I thought we'd just bring Mary into this, and I'll drop out, and you guys can continue on this conversation.
David, if I could just agree with the point that you made. I know with me personally, if I'm not sleeping at a regular time and sort of have structure around my sleep, I really get into difficulty very quickly, and the lack of sleep will very much increase my paranoid thinking. Everything really does start to unravel for me if I'm not being really vigilant about what I'm doing with my sleep. So I couldn't agree more with that.
Do you have any comments on that, Mary?
No, well, I think I said it right at the beginning. I agree. I think it's absolutely essential. And again, so is food, so is physical activity, so is recreation, so is rest, so is time with people that love you. And I think if those things can be kept in balance, then it reduces the stress if you're looking at that stress vulnerability model, which I just think is so valid. The other thing I wanted to say about, Ingi was talking about becoming the person, or, you know, your true self, as it were. And I just recently read an essay by Carl Rogers from the 1950s and about, you know, becoming the person that you truly are. So I don't, you know, it's not all new.
Can I just make another comment about sleep? There are two factors here. One is when it's something, getting your sleep rhythms out is bad for you if you have bipolar. So if you have bipolar 1 and you sleep deprived for one night, you have something like a 10% chance of having a bipolar manic episode after that. So that's one thing. The other thing, though, it can be an early warning sign or a warning sign of things going awry in terms of mood. So that's the other way to look at it. If sleep patterns are going off, you know, that might be an indication of an evolving episode.
Good.
I think also, just to stress what Mary's saying about these other factors, exercise and diet are key. And there were a couple of questions online actually about N-acetylcysteine and omega-3 fatty acids, things like this, antioxidants. You know, I think all of that points to, if you're really looking after yourself and getting a good balanced diet, you're covering a whole lot of those bases as well.
May I just ask all four of you a question? And this has come up from the attendees. The pregnant patient, or the patient is considering a pregnancy, we've got a lot of issues going on there, haven't we? Would anybody like to comment on that?
About pregnancy?
A patient with bipolar affective disorder who's considering a pregnancy or who's pregnant. You know, can we just discuss some of those issues?
Well, I can kick off if you like, and then others can comment. Look, it's obviously an area which is best planned for and discussed ahead of time with treating mental health and general health professionals, so that things can be really set up properly. And my experience has generally been, if that's done and that everything is put in place, that it really can be very effectively managed. The real crunch time is after the birth. During pregnancy is not such a problem as a rule, although certain medications, I should say, are very, very dangerous in pregnancy, especially sodium valproate. Lithium used to be very concerned, we used to be very concerned about lithium, but less so now. But certainly valproate is a very nasty drug in pregnancy. So that's one thing. The other thing is that it's the postpartum period, so after birth of the child, that's a real stress time, I mean, for any parent. And if we just come to the one issue about sleep, we all know about, anybody who's had a child will know the problems with sleep disturbance associated with having a child, and even that in and of itself can precipitate unwellness. And that requires careful planning, and it requires the partner to be involved, and all the sort of strategies which are going to go around ensuring that the person is controlling as many of the things which are controllable in that sort of environment, and also being aware that it's enormous stress for the body in terms of massive flux of estrogens, etc.
Ingi, thank you very much, David. Ingi, would you like to comment as a consumer advocate about the issues that you hear from consumers in relation to pregnancy and childbirth and postpartum period?
I was thinking, actually, when I was listening to David, I had a girlfriend quite a number of years ago with bipolar 1, and I do remember as she got more heavily pregnant, they had to take her off her medications, and then she actually spent the last part of her pregnancy in hospital because she became unwell, and so she had to be monitored and everything. And I think that personally, I mean, I don't have children. I haven't gone down that road myself, but I think that I think everybody has the right to have children if they would like to have children. I do believe in what David was saying, though, that it's something that does need to be supported and monitored, and just to take those extra considerations, to think about those things, and for the parents to think about that too, just to have some useful strategies. But I think people can still have children and have bipolar and still have a wonderful life as a parent and enjoy their children.
Yes, thanks very much. Greg, do you have any comments on pregnancy in relation to psychotherapies?
A couple of things.
Bipolar affective disorder?
A couple of things, and David's already flagged. We know we can predict what sorts of life stresses people are likely to face when they have a child, especially a first child. And that's one of the things we try and do when we intervene in terms of social rhythm stabilisation. So as David was saying before, sleep is critical. And one of the things that most people don't know about sleep is it doesn't just happen because we're tired. It also happens because of the body clock. And what we're trying to do here is there's a lot of evidence that, in fact, one of the core neurobiological vulnerabilities is, in fact, in that body clock. And so the social rhythm stabilisation, getting to bed at a regular time, getting up at a regular time, getting out in the sunshine in the daytime, exercise, we believe that is, in fact, addressing that core biological vulnerability. So that's what we do in terms of setting up a routine life for people, but we also try and predict when life is going to be destabilising. And so bringing an infant into the house is definitely going to do that. So, this is what we call the power of planning, not just reacting to this when it happens, but spending that time during pregnancy planning for what will almost certainly be an extremely challenging time, especially for someone who happens to have this vulnerability. And then, so that's one thing. And then I suppose the other issue is a lot of people with bipolar disorder have concerns about the inheritance of bipolar disorder from them into their children. And so we need to discuss that. We need to discuss what does that mean, what might one's anxieties be around that, what are the facts that are relevant to that, and make sure that the new parent isn't being overly and unnecessarily vigilant about signs of what they might imagine are, early psychopathology in their child, which is not going to be useful for anyone in the family.
Mary, do you have any comments on that?
Oh, look, I think that the planning thing is fantastic and ideal, and the reality is lots of pregnancies are not planned, including people with bipolar disorder. And sometimes you just have to do the best that you can. But again, I guess the biological things become even more important. So sleep, rest, food, sunlight, physical activity, they are just even more fundamental in pregnancy and postpartum. And I also personally think that that psychotherapy becomes essential, because I think infancy, when you have a new infant, I think it's probably the closest that people without psychotic disorders ever get to becoming psychotic. And I think if you already have a known vulnerability towards that, if you have bipolar 1, then I just don't think you can underestimate the importance of having regular counselling.
There's a question actually online about children of parents with bipolar, and I should give a plug, Ingi, for your book called Walking the Black Dog, which is actually it's beautifully illustrated as well, and is really nice for kids to really access it. And Ingi's done a lot of education around this, speak to school children and stuff like that. So I am Ingi's manager. Actually, seriously, if anybody is interested in the book, they should email either me or Ingi.
And I work with adolescents, and a number of the young people I see do have traumatic experiences in their lives because their parents have mental illness. And recognising, I completely agree with what Greg said about not interpreting behavioural signs in children as an early sign of bipolar disorder just because mum or dad has it. And I think there's some really good support groups for young people whose parents have mental illness in a lot of places, so that someone's put the acronym COPMI, which is Children of Parents with Mental Illness, and there's nationwide networks and there's a lot of local groups. And I think that young people sharing with other young people whose parents have mental illness is really valuable.
Yeah, I agree.
Thank you. Well, this has just been a great evening. It's not over yet, but we're coming towards the end of this webinar. One question that I know Ingi was keen to ask and she hasn't been able to ask was the link between bipolar affective disorder and creativity. Would anybody like to comment on that?
It's this is actually a question I wanted to ask Ingi, and then she asked me back. So it's not really fair.
I handballed it.
But I mean, there's a massive literature on this, and Kay Redfield Jamison has written a course about herself, but she's also written a nice book about famous people with bipolar, and the history is replete with them. I think there's an interesting twist to that a lot of people with bipolar think that they're terribly creative and much more productive when they're manic, but actually they might produce more volume, but it's often not of the same quality. And there was a research study done of this where they had an independent panel of art critics to critique art, which was done either when the patient was manic or euthymic, and actually the art which was done when they were euthymic was much better quality according to the raters. So that's a bit of it's a bit of an interesting twist on the whole thing. But there's undoubtedly a link between creativity and bipolar disorder, and numerous case examples.
Thanks very much. Anybody else like to comment on that?
We've just actually done a review of that enormous literature, and just to quantify the effect, we were saying that the prevalence of bipolar 1 in the general population is somewhere around 1% perhaps. In a large sample of eminent artists, this is a biographical retrospective study, the prevalence was found to be 8.5%. So that's the sort of association we're talking about. But one of the factors there might not be creativity. One of the personality features of people with bipolar disorder is they tend to have high ambitions. They tend to be quite achievement-oriented. And it may, in fact, be sort of, as it were, hunger for celebrity that is the major driver of this, rather than pure creativity. On the other hand, positive mood states, we do know from basic psychological research, are associated with creativity. So some of those milder positive mood states that are very common in bipolar disorder might tend to also lead to genuine increases in creativity, even when in full-blown mania. Obviously, the product is going to be perhaps not so good.
Can I make just a little comment about that? Because I'm an artist and a writer and a singer and a musician and one of these bipolar types that are creative, and I know David asked me the same question about what my take is on it, and I'd like to say first and foremost that I think I was born creative and I came from a creative family. There's also a lot of mental illness in my family, but I think that what the disorder does is it drives it. You get this creative edge when you're more manic, and as I think Greg mentioned, I tend to be very goal-orientated and very driven. And one of my friends said, few people can probably compete with someone with bipolar disorder when they're in that really creative, productive zone. You just have this, you really do have this fire that enhances everything, drives everything. And then, of course, you can get into a little bit of trouble because you're not eating properly and all that kind of stuff. You get overstimulated. But another point I would like to make is that after I I tend to be creative then. It's like you've come out of full jaws of death type experience from being severely depressed into this I'm alive again, and it's almost cathartic. I'm very, very creative when I come out of depression.
Thanks, Ingy. Mary, would you like to comment on creativity and bipolar affective disorder?
I would actually. I'm not sure that it's just bipolar, but I actually think people with depression also, especially through poetry, I think, are often able to express something about, what was traditionally called the dark night of the soul, in a way that other people can't put into words. And some of the most, poignant and beautiful poetry comes from people who've been in the pits of depression. So while we probably don't think of it as obviously being a creative state, I think that some people can, out of that state, express something about the human condition that other people often can't put into words.
Like Pink Floyd.
Well, on the note of Pink Floyd, which I think is a really good note to start a night off on, but unfortunately we'll have to end it. You have been an absolutely great panel. I've been giving comments via text on how good you all are. That was a very engaging webinar. Ingy, you discussed the person who has lots of creativity, but often experiences shame from their behaviours when they are manic. David, you eloquently described the biopsychosocial model as I have never heard it described before, and the importance of sleep and those other concepts that prevent people from becoming manic. Greg, you talked about hope, I think. Hope was coming through in all your psychosocial, in all your psychological therapies. And Mary, you were very eloquent about our own biases and the transference, counter-transference issues that we all experience when somebody is not themselves and unwell. On behalf of all the attendees and on behalf of myself, I would like to thank you all. You've been just a fantastic panel, and we look forward to seeing you again on an MHTN webinar. Say good night to everybody.
Good night,
Good
everybody.
night. Good night. Thank you, everyone.
Thanks.
Season's greetings to everybody as well.
Bye-bye.